Right, here is a short audio lecture to finish off, or almost finish off, Chapter 22, Diseases. The first one, well, I'll say first that hopefully the audio is decent for you. Occasionally it could be a little clanky, so to speak, and hopefully there's not a lot of extra noise, as that can cause some pretty, or some issues with the background. So tuberculosis has been around for a very long time, thousands of years. It is sometimes referred to as the White Plague, in direct contrast to the Black Plague caused by Yersinia pestis. But humans can actually become infected quite easily if they are exposed to the bacteria, but they don't often get disease. So that's pretty interesting. Of those who do develop disease, 85% of those cases are going to be contained to the lungs. And when you think of tuberculosis, you probably think about a lung disease. There are 3 clinical types of tuberculosis: primary, secondary, and then disseminated or extrapulmonary. And your textbook refers to the disseminated or extrapulmonary form as miliary. Alright, so causative agent is Mycobacterium tuberculosis. Alright, so you'll need to know Mycobacterium for the causative agent. As we've mentioned multiple times in lecture as well as in lab, this organism is acid-fast. So it is slightly gram-positive, but it contains mycolic acids, which are basically waxes within the cell wall. And so you need heat and you need a very strong dye to actually stain these cells. And these little pinkish purple red strings are the actual bacteria. And we've done this stain before in the lab. We use, I think it's Mycobacterium smegmatis, but because of the stain, because of the acid, it is kind of slightly dangerous, so we don't use it very often. Because of that mycolic acid, though, it is resistant to drying. It is resistant to disinfectants. So that means if it is in the environment, if it is on a surface, it can actually survive for quite a long time just on the surface, ready to be picked up and transferred to another living organism. There's what's called the Cord factor, and this is almost like a string that comes off of the bacteria, and it is linked to its virulence, how well it causes disease. And then there are some different strains. Besides Mycobacterium tuberculosis, there's Mycobacterium avium, which is seen in AIDS patients. Right? Very, very rarely is Mycobacterium avium seen in an immunocompetent individual, whereas Mycobacterium tuberculosis can easily cause disease in AIDS patients, but it can also cause disease in what you might consider to be healthy patients. But often those healthy patients already have some sort of underlying health condition, whether it is immunosuppression because of some medication, or just had a very high dose, infectious dose of the organism. And then there is Mycobacterium bovis. As you can hopefully pull from that name, it comes from cows or cattle. And Mycobacterium bovis can cause infection from unpasteurized milk. And it can also cause disease with cattle worker. So there are places where people within the United States might get vaccinated, and that's going to be when there is a high probability that cattle in their area could be at risk. That vaccine is normally used for cattle, but sometimes the disease will still pop up. All right, so primary tuberculosis. This is going to be the initial infection and the minimum infectious dose, all right, is approximately 10 cells. So that is quite high in terms of its infectious dose. Just to have 10 bacteria cells is incredibly impressive. And the reason for this is that if the Mycobacterium tuberculosis gets down into the lungs, you have the alveolar macrophages that live there that are designed to be present and be able to engulf, phagocytize any bacteria or garbage that is coming into the lungs. But instead of being killed inside the macrophages, the tuberculosis organism can actually expand and multiply. And the escape leads to cell-mediated attack on bacteria. And that means that the T cells get activated. And those cells get drawn to the lungs, and you end up with the formation of tubercles. Calcification of areas within the lungs that the mycobacterium is, and the immune cells want to basically barricade it. It doesn't work well for the macrophages to kill it because the bacteria are able to survive inside them. And so, with a cellular response and the subsequent inflammation, the immune system does a pretty good job at isolating that bacteria and walling it off, basically creating a barrier. But unfortunately, that does cause damage and impedes the function of the lung tissue. The tubercles are what you see on a chest x-ray. And in addition to, or in that process of making the tubercles, there's a lot of neutrophil activity. And part of that is due to the activation of the T cells. But the neutrophils release enzymes in that area where the bacteria is. And unfortunately, it can't be specifically directed at the macrophages all the time because, at the bacteria all the time because they're inside the macrophages a lot. And so those enzymes will actually cause degradation of the lung tissue itself. And so you end up with what are called necrotic caseous lesions. And there are different types of necrosis, and one of them is caseous necrosis. When you have caseous necrosis, it derives its name from cheese, because if you cut open, not biopsy, but if someone passes from tuberculosis and you open their lungs up, it can actually look kind of like cottage cheese or a soft cheese mass. If you like fresh mozzarella cheese, that kind of survives, lives, is housed in water-like material. And that's kind of what a tuberculosis tubercle is, or looks like, has the consistency of. So once that caseous necrosis or caseous lesions develop, there's a process where it tries to heal itself. The body tries to heal itself by calcifying an edge around that caseous lesion, and then that's where the tubercle actually forms. So it's a calcification of garbage inside the that shell, basically. Right? And because there is that T cell activation, when you have a skin TB test, you have to have the small amount of the antigen injected under your skin, and then go back to have that checked 48 to 72 hours later to look for a reaction. The reason you have to wait for that reaction is because the immune response to TB is actually directed by the T cells, right? This cell-mediated attack method. Well, normally in your skin, you don't have a lot of T cells just hanging out. So you have to give it time for the TB antigen, it's not the bacteria itself, it's just the antigen, to get put underneath the skin for it to basically send out the signals that there's a problem there. If you've been exposed to or have TB, your T cells are going to be at high numbers. You're going to, or your cells then are going to specifically target the antigen that's been injected into your skin for the T cells to arrive. The T cells arrive, they cause an inflammatory response, and you have the readout of the positive skin test. All right, secondary TB is what happens when the live bacteria from the tubercles become reactivated, and they will generally expand, or they get out of the tubercles, and then you start the process all over again. All right, and in this case, you develop more tubercles. All right, there is chronic tuberculosis where those tubercles just expand over time, and eventually it takes over the lung tissue. All right, you may have heard of consumption. All right, it took me a long time to understand that consumption, which I'd heard about, was actually a very, very bad prognosis of tuberculosis. All right, these are severe symptoms. There's violent coughing, the lungs are irritated, and so there's just that natural coughing reflex. There's greenish to bloody sputum, a low-grade fever. This could be constant. Along with that low-grade fever, there can be night sweats, which can be extreme. There's anorexia, weight loss. Your body is just consumed by the disease. All right, and then obviously there's going to be fatigue because your body, all of your cells are not getting the oxygen they need, and then chest pain. So that's secondary tuberculosis, reactivation of primary. Then there's extrapulmonary in your textbook, the miliary, where it's outside of the lungs, extrapulmonary. And so the bacteria get out of those tubercles and they move from the lungs, and so they can go to the regional lymph nodes, they can go to the kidneys, they can actually go to the bone, genital tract, and then the brain and meninges. This is not a good sign for the patient for survival. This is typically only going to be seen in immunosuppressed patients, and then also young children if they happen to come into contact with the bacteria and get the disease. So this is a picture out of your textbook. It shows a person breathing in the bacteria, and this is actually a good picture. It's very small here, but if you look at it in your textbook, you can see the rod-shaped cells that a person breathes in, and then it gets down through the bronchi, down into the alveoli, and what you see in this picture is this here, where you have the bacteria inside that tubercle, inside the alveoli, and the immune cells are these individual circles. They try to wall that bacteria off, and that creates the tubercle, sometimes referred to as granuloma. And when it becomes completely calcified, they're called a Ghon complex, G-H-O-N. All right, and then this last part here is when the disease gets reactivated, the mycobacterium escape from that tubercle, and they can go on to be spread. All right, here's just an example of the skin test. All right, so how do you treat this? All right, you treat it for a very long time with multiple antibiotics. Tuberculosis, because it's been around for so long, is extremely drug resistant in many cases, or even just multi-drug resistant. So typically a patient will be on 2 to 3 antibiotics at the same time, and this treatment can last for 6 to 9 months.